In this section, we cover the adrenal medulla and the regulation of catecholamines. So the sympathoadrenal system, or the fight or flight response system, is the system that's associated with catecholamine regulation. So if you recall from the introductory section, we said the catecholamines, norepinephrine and epinephrine, are derived from the amino acid tyrosine. The tyrosine undergoes a series of reactions, as shown in this slide, to produce norepinephrine and epinephrine. Epinephrine and norepinephrine both get metabolized to their respective metabolites called metanephrine or normetanephrine, as indicated in the slide. The catecholamines in general work on several receptors. The most common one are called the alpha and the beta adrenergic receptors. There are 2 alpha receptors and 2 beta receptors, and both epinephrine and norepinephrine work on various receptors to result in various functions. So for example, epinephrine can bind to either of the alpha receptors or the beta-1 receptor or the beta-2 receptor to result in increase in the rate and force of contraction of heart muscles, increases metabolic rate, it dilates the bronchioles, stimulates lipolysis, dilates pupils, inhibition of gastric secretion, and so on. So as you can see, epinephrine is one of these classic fight or flight responses, hormones that is necessary for acute stressful events. Norepinephrine, on the other hand, has a more specific and limited set of activity, and especially its activity centered around constrictions of blood vessels. And its primary function is to increase the SVR, or the systemic vascular resistance, and therefore increases blood pressure. This is one of the reasons we use norepinephrine in the ICU, especially in the situations of septic shock, because in septic shock you have very low SVR, and by using norepinephrine you can really clamp down on the vessels to increase SVR and bring the blood pressure back up again. So this is a question that talks about what happens when there is perturbation in the catecholamine system. So asymptomatic 50-year-old woman has hypertension, urinary excretion of catecholamines is increased, a CT scan shows a suprarenal mass. Which of the following is most likely in this case? So first of all, the diagnosis, as most of you already have guessed perhaps, is pheochromocytoma, because this is a situation where you have increase in urinary catecholamine excretion and usual manifestation is hypertension. And this imaging usually shows a large adrenal mass. And pheochromocytomas are most commonly a benign neoplasm of the adrenal medulla. So the correct answer is B. And here's the basic signs and symptoms and the diagnosis for how to approach pheochromocytoma. So first of all, pheochromocytoma is a benign tumor of the adrenal medulla, and the usual presentation is headache, sweating, and palpitations, and oftentimes physically patients present with hypertension. There's also anxiety, nervousness, could have some heat intolerance, weight loss. And so if you look at the constellation of symptoms, you need to have a high index of suspicion to make the diagnosis of pheochromocytoma, because many times many other diagnoses can fall under this category, like heat intolerance, weight loss. Nervousness can also be hyperthyroidism. Sometimes people can present with chest pain as well. And so it's important to recognize that the symptom complex is fairly nonspecific, but you need to put the whole picture together. So the diagnosis is really made by measuring the catecholamines and their metabolites, and more importantly, their metabolites directly in the urine or in the plasma. So the 24-hour urine metanephrines, which is the metabolites of epinephrine and norepinephrine, is very useful in the urine or in the plasma. And it's important to recognize that the metabolites are a lot more sensitive than the parent catecholamines, because the parent catecholamines are very transient and can get degraded quickly in the blood, whereas the metabolites can stick around for a longer period of time. In this particular case, it's always important to recognize that the biochemical tests have to be done before imaging tests. And the reason for this is simply because there's at least a 1 in 10 chance of trying to find something by scanning in the abdomen, where you get something called an adrenal incidentalloma. So in other words, 1 in 10 people have an adrenal incidentalloma, and you don't want to be scanning people's bellies without really knowing what the diagnosis is, because oftentimes those lead to more anxiety, more testing, and unnecessary surgeries. So again, the take-home message is do the biochemical test first, and then the imaging test. This is an example of how an adrenal pheochromocytoma looks like. They're usually not very subtle. They clearly have a suprarenal mass, as shown in this MRI imaging, which is the preferred modality. There's also something called the 10% rule of pheochromocytomas, where 10% of these tumors can be malignant, 10% can be bilateral, 10% can be extraadrenal, and 10% can be in children and familial. 10% are associated with a syndrome called MEN, and 10% are recurrent. So again, for the most part, 90% of the part anyway, most of these tumors are benign, are unilateral, and are sporadic. So this concludes the section on adrenal medulla, and in the next section we will cover the regulation of carbohydrate metabolism and the pathophysiological consequences, which is primarily diabetes.